So next session is diabetology. Two topics are there. Chairperson for the session is Dr. Jayanto Chakraborty and Dr. Parthopratim Das. First speaker, Dr. Indira Mensom, and topic is use of gliptins in the elderly.
Good evening. The delegates, after heart, we are now coming down to the pancreas. There are two topics, and Indira is one of the young endocrinologists of the city. She is very known to all this academic forum. Indira, please.
Thank you, sir. Respected chairperson, sir, learned audience, it's seniors and juniors. It's indeed a great pleasure and an honor for me to be delivering this talk today. So my topic today is gliptins in the elderly. Is it an irresistible choice? So diabetes management in elderly is different because we'll have a brief account of the current scenario in the elderly. The treatment goals in the elderly needs to be more relaxed, and then there are challenges of managing type 2 diabetes in elderly, and then we will discuss the role of gliptins regarding their efficacy, their overall safety, whether it is renal safety or whether it is the lesser chances of hypoglycemia, what are their overall cardiovascular risk, and also no negative effect on certain factors like bone health and cognitive function. So the world is growing older. The world's older population continues to rise at an unprecedented rate, and in 2016 it was 8.5%, but by 2050 it will be 17%. And among the older populations, non-communicable diseases are the main concern. So as can be seen from this chart, we see that the health costs or the expenditure on health keeps on increasing as one grows older, and therefore when somebody is more than 65 years old age, the spending on health and other infrastructures could be more than around 6 times older. In fact, there is a new term known as senagers, that is seniors but like teenagers. So we know that teenagers are actually the new consuming class, but what we understand, so senagers is a term given to the elder people who are above 60, and they are the new consuming class. They constitute 12% of India's population, but then India's aging population is rising by 3% per annum, and this is faster than the younger age groups. And so by 2025, India will be one of the youngest nations in the world, and yet we will be one of the most oldest nations in the world. And according to the Confederation of Indian Industry Studies, it shows that the market value for the medical and lifestyle needs for the elderly people or the senagers is more than 43,000 crores, and it is growing. And yes, so it is a state of affairs all over the world, whether it is India or whether it's in other parts. And therefore, there are challenges in managing elderly populations because patients who are old have had diabetes for a longer duration of time, they have lesser beta cell function, and they have more alpha cell defect. And the traditional secretagogues, as we know, like for example, the sulfonylureas can cause hypoglycemia more easily. They have other comorbid conditions, and novel agents like SGLT2 inhibitors could be relatively contraindicated in these groups of people. And if you look at the beta cell decline in patients who are having pre-diabetes, whether it is impaired fasting glucose or whether it is impaired glucose tolerance, we see that the progression to diabetes is much more rapid in the elder population compared to the younger. And what about sitagliptin? Sitagliptin is an important gliptin. We know that it does not cause hypoglycemia. It causes the release of insulin by a nutrient-dependent mechanism, that is only when there is adequate hyperglycemia in the blood would it cause the secretion of nutrients. And it is effective in the elderly, whether it is less than 75 or more than 75. And sitagliptin's efficacy is known across the spectrum, whether the person is young or the person is old. And it is effective even in those with poor beta cell function. Sulfonylureas, for example, would not work in somebody with poor beta cell function, but sitagliptin is effective, and we are also aware of the fact that aging is associated with a decline in the glomerular filtration rate, and the longer duration of type 2 diabetes is also associated with a lower EGFR. Therefore, it is expected that elderly patients with diabetes would have a lower EGFR. But the good thing is that all the 3 dosages are effective in elderly in all the EGFR categories. It's just that we need sitagliptin can be given across the stages of renal disease. It's just that we need dose modifications. So for somebody with an EGFR more than 45, we would give 100 milligrams OD, whereas somebody between 30 to 45, we will give 50, whereas in less than 30 or end-stage renal disease on maintenance hemodialysis will give 25 milligrams. So ultimately, the lower doses would work in patients with renal function, thereby actually saving the cost. So this is the study. They are showing that all 3 doses are effective in the elderly also, and this is what I have just mentioned, that it is effective across the spectrum of CKD. And also there are studies to show that it could have a favorable effect, sitagliptin would have a favorable effect on the progression of albuminuria. In other words, it could decrease the albuminuria, and this may have to do with the presence of DPP-4 in the renal podocytes. In the TICOS study, which is the cardiovascular outcome study of sitagliptin, it was shown that yes, sitagliptin was associated with a stable EGFR when it was studied in this study for over 4 years. And then another important concern in the elderly is hypoglycemia. Why is it a concern? Because firstly, it is difficult to recognize because the symptoms are non-specific. So an elderly person suffering from hypoglycemia may not have the typical symptoms of palpitation, tremulousness, or sweating, but rather just feel weak, faint, or just become unconscious. So because they may not have the autonomic symptoms also. So it is very difficult to recognize the symptoms, and it is easily misdiagnosed as stroke, vertigo, or other visual disturbances. It could be misinterpreted as some behavioral changes, and because of the atypical presentation, the workup might be done on a different line, let's say for hyponatremia or others. And like I said, because they would have autonomic neuropathy, there are little warning signs that are typical of hypoglycemia. The autonomic features could be decreased, and patients with dementia are unable to communicate their feelings. So firstly, it is difficult to recognize. Second, there is a interplay of comorbid factors, whether it is old age, malnutrition, because of acute illness, or because of, let's say, the presence of other comorbid conditions like renal failure, like hepatic failure, and blunted counter-regulatory response. So in other words, we do not want hypoglycemia in any of our patients or diabetes, but definitely never in the elderly, because it is so difficult to realize and is so easily caused. And therefore, we would prefer agents that do not cause hypoglycemia, like gliptins, like sitagliptin. And if you look at this study, sitagliptin with insulin was better for glycemic control with less hypoglycemia than insulin alone. So yes, there are studies even of the use of sitagliptin in patients, in admitted patients in the hospital, where patient would be given a basal insulin to target the fasting, and sitagliptin would be given to actually target the postprandial with good outcomes. So there are lesser chances of hypoglycemia, which is a big challenge in patients with diabetes with elderly. And interestingly, gliptins have a differential effect on the glucagon levels. So when the blood glucose is high, actually the glucagon levels come down with the use of gliptins, but when there is hypoglycemia, in this study, which was with vildagliptin, it was shown that actually the counter-regulatory hormone, that is the glucagon level, rises, and maybe this has to do with the effect of the DPP-4 inhibitors on the GIP as well as the GLP. We know that GLP decreases the glucagon secretion, whereas GIP actually increases the glucagon secretion. So, and this is what the study is trying. So in other words, gliptins, for example, sitagliptin, do not cause hypoglycemia on their own, and also they could be protective against hypoglycemia because of the fact that there is an increased glucagon response in response to hypoglycemia. Regarding aging and cardiovascular disease, we know that even age, just age, is a risk factor for cardiovascular disease. In fact, what is happening in diabetes is something that is happening in the aging. So in other words, we could say that diabetes is also accelerated aging. And in aging, why there is a risk of diabetes? Because of many cardiovascular disease, because of many comorbid conditions, presence of diabetes, presence of adiposity. As a person ages, the adiposity increases, whereas the muscle mass decreases, and also lack of physical and also other cardiometabolic risk. At the same time, there is increased fatigability, decreased muscle mass, decreased endurance capacity, muscle wasting, and as a result of which there is decrease in the physical activity. And therefore, aging is associated with cardiovascular disease, diabetes is associated with cardiovascular disease, and therefore we want anti-diabetic agents that would be cardiovascular safe, and that is what has been proved time and again with gliptins like sitagliptin in studies like the TECOS. And if you see this TECOS study, old age was associated with worse outcome. So this chart is trying to show people younger than 75 years and more than 75 years. So whether it was a primary cardiovascular outcome, secondary, whether it was hospitalization for heart failure, all-cause mortality, acute pancreatitis, and all these complications, old age is an independent risk factor for all these complications, and including even, let's say, bone fracture. Look at this, there is also an increased risk of bone fracture in the elderly, which we know. And again in the sitagliptin, in the TECOS study, sitagliptin was not associated with worsening of outcomes in the elderly. In other words, sitagliptin was safe in elderly patients across the spectrum. And in this study, which was a retrospective study from Medicare data in the US, what it was found that there was a no increased risk of cardiovascular events in older adults who are initiated at DPP-4 inhibitors versus a sulfonylurea. So this was a retrospective data from the Medicare population. Interesting, this is a very interesting slide where it has shown that we all know that elderly patients are at risk of fracture. We know that diabetes patients are at risk of factors. These are because of bone-dependent and bone-independent mechanisms. Bone-dependent mechanism because there is greater bone loss in diabetes, but also bone-independent mechanism. For example, retinopathy, autonomic neuropathy, all this increases the risk of falls. So in other words, we do not want agents that would increase the risk of fracture. In fact, we would prefer agents that decreases the risk of fracture. And if we look at the fracture risk associated with common medications used in treating type 2 diabetes, we are all aware of the fact that thiazolidinediones are associated with fracture, and also novel agents like the SGLT2 inhibitors are also associated with loss of bone mass. But the incretin group of drugs, whether it's the GLP-1 receptor agonist or the DPP-4 inhibitors, do not decrease the bone mass, and in fact there are studies that shows that they could be improving. These are small studies, they need to be confirmed on a larger scale, but there are studies that show that they could actually be improving the bone mass also. So here in this study, which was published in the Journal of Bone Mineral Metabolism, it is the most high index journal of bone diseases, where here it was shown that bone safety of sitagliptin in postmenopausal women with type 2 diabetes, and it could be sitagliptin's effect on bone metabolism is likely to be mediated through inhibition of the bone resorption. This needs to be studied. These are preliminary data, but at least it shows that it is at least neutral or beneficial for patients with impaired, for patients who are at risk of osteoporosis. Again, sarcopenia is a chronic complication of type 2 diabetes, and it is seen in the elderly where there is low bone fat muscle mass. In fact, sarcopenic obesity is associated with metabolic syndrome and type 2 diabetes. So there is sarcopenia or low muscle mass, at the same time there is adiposity. And the muscles are the most insulin sensitive organs of the body, and sarcopenia results in severe insulin resistance, at the same time also a tendency to fall and thereby increasing the fracture risk. Gliptins has been shown to increase the muscle mass. These are preliminary studies, need to be confirmed, but at least they are not harmful for the muscles, and these are the various parameters which showed in different studies. We know that type 2 diabetes is associated with impairment of the cognition. In fact, Alzheimer's disease is a type of insulin resistance that occurs in the brain. So at least in these studies, type 2 diabetes itself is a risk factor for dementia, and the same pathogenetic mechanisms that cause dementia could be working in the metabolic level also. So again, in this study, interesting study, which was published in the diabetes research and clinical practice, it was found that in patients with the use of gliptins was associated with improvement in the mini mental score examination. So, and then we are aware of the fact that yes, gliptins almost do not have any side effect, no hypoglycemia, no weight gain, and therefore the adherence is much, much better than other conventional alternatives we know. So to take home message is that elderly with type 2 diabetes is a fast growing population. We are going to become one of the oldest nation in the world in another 6 years, and therapeutic choices often fall short of desirable efficacy or safety. If it is efficacious, it's not safe. If it is not safe, it's not efficacious. So we want an agent that is safe, and gliptins are effective across the age spectrum, across the EGFR spectrum. There is no risk of hypoglycemia on their own. They are cardiovascular safe, and probably they have a better profile on the bone health, on the muscle mass, and probably a positive impact on the cognition and better treatment adherence than many, many other common oral anti-hyperglycemic agents. Thank you, sir.
Thank you, Dr. Indira Maisnam, for your timely presentation of a very good lecture. Now the paper is open for discussions. Is there any question? If there is no question, thank you. Just one comment that the sitagliptin these gliptins are very good for the elderly, but two things must be noted. That first is the dose should be reduced. Dose should be reduced because elderly are the compromised, renal compromised, and it should not be started with insulin or secretagogues because it can cause hypoglycemia. It's treated with a combined drug. Do you agree with me? Thank you. Thank you. Next. Our next speaker
Topic is hypoglycemia, current concept. Speaker, Dr. Palaniappan. Sir, please.
Very much trouble to fly from Madurai at the end of this session. Thank you, Dr. Palanipam. Please start.
Good evening, everyone. Everyone are hypoglycemic. I am going to discuss hypoglycemia and update 2019. Thank you very much, Dr. Arul Raj sir, Dr. Jyotirmay Paul, and Sibandhu Ghosh, and everyone and each and everyone. And thank you, Chairperson, for his kind introduction. I am from Coimbatore. I am running 50-bedded multi-specialty hospital. I want to discuss hypoglycemia update. I am going to discuss evidence-based medicine as well as experience-based medicine and expert-based medicine. So I am going to discuss in these headings what is the definition of hypoglycemia and how will we classify and how will we management, what are the recommendations. This is the definition of hypoglycemia that is called Whipple's triad, that is presence of symptoms suggestive hypoglycemia, that is autonomic symptoms, not adrenergic, both adrenergic as well as noradrenergic, adrenergic as well as acetylcholine manifestation will be there, and neuroglycopenic symptoms will be there. So in this slide, actually neurogenic or autonomic symptoms, it's very, very important. In type 2 diabetes mellitus or type 1 diabetes mellitus, sometimes it may be absent, most of them or may be absent in hypoglycemic unawareness patients. But definitely the sweating will be present. For all type 2, all diabetic patients, the neurogenic symptoms are at least sweating will be there. And many times in the office, there will be anger, agitation will be there. And neuroglycopenic symptoms, difficulty in speaking, difficulty in concentrating in works, and weakness, confusion, drowsiness, and the vision changes, and dizziness will be there. These are all the symptoms you should have. That is neurogenic symptom, neuroglycemic symptoms. And low blood glucose less than estimated blood glucose is less than 70 milligram per deciliter, which will be respond to carbohydrate carbohydrate load. All three things, if it is present, the diagnostic of hyperglycemia, this is Whipple triad. So after that, so this is the Whipple triad to diagnose hypoglycemia. And classification of hypoglycemia nowadays, ADA 2018-19, what they are telling, level 1, 2, 3. Level 1 is blood glucose estimation less than 70 milligram per deciliter. Level 2 is less than 54 milligram per deciliter. Level 3 is a severe hypoglycemia associated with this altered mental status or altered physical status or both. So level 1 or level 2 or level 3. In what level the patient is there? So you have to diagnose hypoglycemia, and level you have to assess, and depends upon the severity, mild, moderate or severe. Mild, usually less than 70 milligram per deciliter, there will be neurogenic symptom will be there. Autonomic symptoms will be there. Moderate autonomic symptoms or neuroglycemic symptoms will be there. Patient is conscious. In severe, patient is altered sensorium will be there. Patient require assistance to treat. And plasma glucose invariably less than 54 milligram per deciliter. So what are the causes of or precipitating factors for the hypoglycemia? If you know diabetes, you are pandit in medicine. Nowadays, if you want to be a very good diabetologist, a general physician, if you are capable of preventing hypoglycemia as well as managing hyperglycemia, your practice will be enormously will be very good. So what are the causes or precipitating causes for hypoglycemia? Usually there is an imbalance between the drugs and the food and exercise. If there is an imbalance, you can get hyperglycemia as well as hypoglycemia. That is, so imbalance between the drug and diet and exercise. So if there is an imbalance and the patient is having previous history of recurrent hypoglycemic unawareness and recurrent history of hypoglycemia, patient diabetes duration is prolonged diabetes and associated with autonomic dysfunction, and patient is having acute kidney injury or CKD or AKI on CKD, or the patient is associated with sepsis, severe sepsis, patient may get hypoglycemia. And the age group is preschool age, adolescent age group, and especially in the type 1 diabetic patients, more prone to develop hypoglycemia. And poorly intelligent, not adhering to your advice. And elderly individuals, hypoglycemia is very common. Pregnant individuals, hypoglycemia is very common. And associated with cognitive dysfunction and hypoglycemia, there is directly proportionate. If recurrent history of hypoglycemia will result in cognitive dysfunction. So you have to address properly. So these are all the important things, and important drugs can precipitate hypoglycemia. When the patient type 2 diabetes mellitus on oral ADD plus insulin, if the patient is having sepsis or respiratory tract infection or urinary tract infection, especially quinolones, even norfloxacin, ofloxacin, levofloxacin, moxifloxacin, anything can precipitate hypoglycemia because it will increases the insulin level. And another thing is mainly azithromycin, clarithromycin can precipitate hypoglycemia. Many times you are treating adequately with the 25% dextrose, still it's recurrent hypoglycemia. Patient is on levofloxacin or ofloxacin infusion for the sepsis. If you don't stop the ofloxacin, you cannot correct the hypoglycemia. So drug-induced hypoglycemia is very, very important. This is source. Where is the source? You have to control the source. In sepsis, you have to control the source. Like that, hypoglycemia precipitating source, it has to be identified properly, and it has to be addressed properly. And all the oral ADD or insulin can produce hypoglycemia. Especially insulin and sulfonylureas can precipitate hypoglycemia. And all drugs you can get. In my clinical practice, metformin also can produce mild form of hypoglycemia. And even other drinks, all other drugs, even AGAs also can produce hypoglycemia. But management is simple things. Simple carbohydrate, you have to give all the drugs. But especially AGAs, agorbos, you have to give only glucose, nothing else. So all the oral and ADD or insulin can produce hypoglycemia, but much more common in sulfonylurea or glinides and insulin. It's a moderate to severe hypoglycemia you are getting. In AAC 2019 guidelines also says, as far as possible, avoid hypoglycemia, avoid weight gain is the main theme to management of type 2 diabetes mellitus. So all drugs can produce hypoglycemia. So here hypoglycemia management protocol, how will you management? First you have to recognize high index of suspicion is very, very important. If there is an abnormal behavior, if there is a patient with type 2 diabetes or type 1 diabetes mellitus, altered sensorium, unless proved otherwise is hypoglycemia. You have to prove it. And patient is in altered sensorium and sweating. Unless proved otherwise it's a hypoglycemia. You have to do the capillary blood glucose estimation properly, and you have to confirm it. Many times you are taking capillary blood glucose very half trough or quarter troughs, you are putting in the glucometer, you are getting 30, 40. You have to do the proper capillary blood glucose estimation. If it is right and less than 70 milligram, you have to treat. Depends upon the status, whether it's a conscious or unconscious, with IV access, without an IV access, with support, medical team support or without support. Depends upon that. You have to recognize, first suspect, and then you confirm the blood glucose and confirm hypoglycemia. After that, differentiate mild, moderate or severe. Depends upon that, the treatment is absolutely varies. And treat the hypoglycemia immediately, whether treatment with the oral carbohydrate, simple carbohydrate, or IV or IM injections. And after that, avoid over-treating. Avoid over-treating 25%, 2 points, 100 ml, two times. It may result in 450 milligram. So avoid over-treating hypoglycemia and avoid future hypoglycemia in future, how to manage. And after that, steps to address hypoglycemia, first recognize that is autonomic symptoms. The autonomic symptoms are neurogenic symptoms and neuroglycemic symptoms. Recognize and confirm with blood glucose and treat with the fast sugar, that is simple carbohydrate diet. Simple carbohydrate diet you have to give, and then it has to be given. It has to be given, and within 15 minutes you do the capillary blood glucose estimation. If it is more than 70, leave it. If it is less than 70, again you give the simple carbohydrate in a conscious patient. And eat usual. After that, the blood sugar is normal. So further hypoglycemia has to be prevented by intake of complex carbohydrate diet as well as or snacks with protein. It has to be given to avoid future hypoglycemia. Simple carbohydrate diet. What all the common diet is available? 3 teaspoonful of sugar or 6 sugar cubes, or 1 teaspoonful of honey you can give, or juice. In conscious patient only you have to give juice, otherwise aspiration pneumonia you can get it. So 150 ml of juice you can give, or 6 lifesavers you can give. All these things you can give. So this is conscious patient, mild hypoglycemia, moderate to severe hypoglycemia, and the patient there is no IV access. You have to give injection, glucagon, IM or subcutaneous injection. It is freely available. You have to advise them, the patient, those who are having recurrent hypoglycemia, and discuss with the diabetes healthcare team. And the patient who is having severe hypoglycemia, unconscious patient, IV access is available. Immediately you have to give 25% dextrose, 100 ml. It has to be given in 1 to 3 minutes. And again you do 15 minutes. Capillary blood glucose, still it is present. Again you start with 25% dextrose. If it is not available, you can give, that is 50 ml of 50% dextrose, or 250 ml of 10% dextrose, or 500 ml of 5% dextrose. Depends upon the condition. Many times type 2 diabetes is associated with volume overload. This patient 25% is the ideal drug. So this has to be given. Again 15 minutes you repeat the blood glucose, revert to normal. Then you have to give simple oral carbohydrate diet 15 gram. And after that you have to give carbohydrate, that is complex carbohydrate along with protein. At the time of diagnosis, if it is in the morning food. If it is afternoon, lunch food, or dinner. Like that you have to give, it will prevent the future hypoglycemia. And treatment of severe hypoglycemia in conscious patient, treat with 20 gram of simple carbohydrate, and retest 15, same protocol, you have to follow. What is the guidelines in ADA 2019 or standard of standard of care, diabetes care in standard of medical care in diabetes 2018? What it says? Individuals with recurrent hypoglycemia, always type 2 diabetes mellitus or type 1 diabetes mellitus, you have to ask symptomatic hypoglycemia or asymptomatic hypoglycemia. You have to take the history and act accordingly. And glucagon, all the things already I have enumerated in detail. You have to do the SMPG. If the patient history of hypoglycemia, ask the patient to do SMPG. Which food you have to modify depends upon the SMPG. 8 readings, you have to modify your regimen as well as diet regimen, you have to modify, and meal snacks has to be given properly to avoid future hypoglycemia. Hypoglycemia recommended glucagon. Glucagon is no more, it's a healthcare provider injection. It has to be given to the patient and healthcare, in the family members, you have to teach everybody as well as in the school educator, in the school also it has to be given in the type 1 diabetes patients. So, school caretaker, all caretaker you should give. In the office also it should be there. And you should educate where is the glucagon, where it is kept, how to put, everything should be taught to the healthcare provider or assistants. So it is no more a healthcare provider injection. It should be given in the public. It should be taught to the public and you should act appropriately. And hypoglycemia, unawareness, if there is one history of hypoglycemic unawareness, you have to re-evaluate your regimens, all the regimens, previous oral anti-diabetic drug or insulin regimen, it has to be modified, especially insulin has to be reduced or especially sulfonylurea dosage has to be modified according to your SMPG. And hypoglycemia recommendation wise, usually once hypoglycemic unawareness is there, so after that, previously your target is 7, and fasting is less than 100, postprandial less than 160. Now the patient is having hypoglycemia unawareness. Once you have to increase the target, 7.5, 120, 200, like that you increase the target. Then only the patient will feel the adrenogenic, that is autonomic symptoms. After that, they will not get to feel the autonomic symptom, you have to increase the target. Then only the patient can able to feel and further hypoglycemic unawareness will be prevented. And ongoing assessment of cognitive function is very, very important in hypoglycemic patient. Cognitive dysfunction is recurrently, the patient is having decline in cognitive dysfunction, suspect hypoglycemia, recurrent hypoglycemia, you have to modify it properly. And especially the hypoglycemic individual, type 1 diabetes mellitus patient, if there is hypoglycemic, repeated hypoglycemic unawareness is there, subject them for continuous glucose monitoring and that is pancreatic transplantation, islet transplantation you have to advise. Another important thing is profound hypoglycemia. In my clinical experience for the past 20 years, I have encountered 10 patients with profound hypoglycemia. What do you mean by profound hypoglycemia? Hypoglycemia lasting for more than 12 hours, which is not recognized. Patient is coming after 12 hours, this is profound hypoglycemia. You are putting them on 25% dextrose, for within 1 to 3 minutes, patient is not recovering. Still the blood glucose is normal, but patient is not recovering. What do you suspect? So precipitating cause has to be addressed and source control should be addressed properly. So you have to maintain the glucose between 70 to 150 and you have to give the continuous dextrose infusion continuously. Patient may require 2 to 3 days to recover from the altered sensorium. Severe agitation will be there. You have to tie up the patient. You have to manage in the ICU 2 to 3 days. After that, only patient will recover. During that period, profound hypoglycemia sometimes may be associated with hypokalemic periodic paralysis. It also has to be addressed. Sometimes profound hypoglycemia, patient may be having acute coronary syndrome. Profound hypoglycemia, patient may be associated with that is structural brain damage may be there. So you have to do CT scan brain, plain or contrast or both, and treat accordingly. In especially elder, that's a pediatric age group, if the patient is having associated cerebral edema, you have to add mannitol also. In off-label indication is recurrent profound prolonged hypoglycemia. Off-label indication is injection decatron you have to give. And you have to stimulate the MND receptor agonist. You have to give amantadine, also, and amantadine, and cerebrolysin, Admenta. All this will stimulate the brain and fast recovery will be there. And many hypoglycemic patients, in my senior has told, we have diagnosed profound hypoglycemia in the cremation ground. Patient is died, some movement is there, just see the patient, just cremation ground, he can able to diagnose a profound hypoglycemia, give 25% patient will awake. So profound hypoglycemia can be diagnosed in the cremation ground also, which is improperly declared death. So this is very important. You have to suspect and you have to wait for 2 to 3 days and you have to treat properly. And prevention of hypoglycemia, how will you prevent hypoglycemia? Target should be proper.
Dr. Pananipam, please conclude.
2 minutes only, sir. Target should be proper. And IIT therapy, insulin infusion therapy, intensive control. VATT studies told it's harmful. Intensive glycemic control is harmful. Other Accord study as well as advanced study also, no benefit. And UKPD study alone, it says non-significant reduction of CVD. But type 1 diabetes mellitus patient, it reduces the cardiovascular death. And you have to be less stringent in various situations, elderly individual, and not having the proper attenders and associated comorbidities, and life expectancy is low. You have to be less stringent, even 8% A1C, fasting 140, postponing even more than 200, some situation. So how to prevent hypoglycemia? So according to that is ADA and EASD 2018 guidelines also says, so you have to avoid hypoglycemia. You have to select the drug according to that. To reduce the hypoglycemia, the drug of choice in India is a DPP-4 inhibitor or SGLT2 inhibitor or GLP-1 receptor agonist or T2 or glitazones to avoid hypoglycemia. And AAC 2019 guidelines also says avoid hypoglycemia, avoid hypoglycemia. And when the patient is on insulin, you have to adhere to the particular, this is the protocol in 2019 guidelines wise. This type of A1 depends upon the A1C, the dosage, and you have to titrate accordingly. More than 180, 20% you have to add TDD. That is 140 to 180, 10%. 110 to 139 plus 1. Less than 70, 10 to 20% TDD has to be reduced. Less than 50, you have to reduce 20 to 40%. This regimen, you have to follow it properly when the patient is on either basal insulin or basal bolus insulin or biphasic insulin. If you treat properly, no hypoglycemia. So you have to treat properly. And perioperatively also during the surgery, when the patient is missing, perioperatively you can get hyperglycemia as well as hypoglycemia. When the target is achieved with the previous drugs, for want of energy, you have to give dextrose. If you want to give 10% dextrose, 5% dextrose, 500 ml, you will get the energy as well as you have to add 8 units of insulin. Or 250 milligram of 10% dextrose, add 8 units. This is the regimen has to be followed to get a proper euglycemic state as well as to prevent hypoglycemia. And the various complications, sudden death. The last month my uncle died. The proper diet is very important. Proper diet. During the hypoglycemia, whatever the patient wants the diet, please give the diet. Don't stick on to the diet. So elderly individual, they know the diet. So my uncle died in the ICU, AK and CKD. Patient want kanji like that. The patient is asking. So you are having acute kidney injury, CKD. Kanji will not be given. You should not take. Like that they have refused. Nurse has refused. Suddenly patient developed atrial fibrillation, ventricular fibrillation, ventricle tachycardia, ventricular sudden arrest. Even after resuscitation, patient, we cannot able to improve. So sudden cardiac death, atrial fibrillation, ventricular tachycardia, ventricular arrhythmia can kill the patient. And profound hypoglycemia damage the brain. Cortical injury, brainstem is resistant to glucose. So brainstem is spared. Usually profound hypoglycemia will result in cerebrocortical necrosis. And various forms, there's insulin pumps are available, repeated hypoglycemia unawareness, pumps are available. So to conclude my talk, all diabetic patients, alter sensorium, unless proved otherwise is hypoglycemia, and record the blood glucose and treat accordingly, unless otherwise proved. High index of suspicion and treat appropriately and not over-treat the hypoglycemia. Source removal is very, very important. Important clinical. Many ICU patients, they are neglecting patients on ofloxacin, levofloxacin, on appropriate culture sensitivity. Still hypoglycemia, recurrent hypoglycemia. If you don't stop the quinolones, the recurrent hypoglycemia will not be treated. And associated acute coronary syndrome also, profuse sweating, type 2 diabetes mellitus patient, sustained hypoglycemia, associated acute coronary syndrome, as well as many times acid dyspepsia, ureteric colic also can produce profound sweating. Dysphoria you can get. The high index of suspicion is very important. Sweating, altered sensorium. You always do CT scan brain to rule out structural brain damage. And profound hypoglycemia you have to suspect. And this is the last 1 minute case, actually, for the PG student. The fasting blood glucose is 214, postprandial is 240, A1C is 7.28, BP is 180 by 100. Patient is on oral anti-hyperglycemic therapy, sulfonylurea glycoside, 80 mg, 1.5 tablet BID, biphasic insulin, 15 units in the morning, 30 units in the evening, and patient hypertension, the BP is 180 by 100, patient is on chlorothalidone 12.5 mg and telmisartan 80 mg. How will he manage this patient? It's a $1 million question for the PG, postgraduate student. How will he manage this patient? How will he manage? Do you want to increase the dosage of morning and night insulin? Fasting is 214. Do you want to increase the bedtime insulin? Do you want to increase the anti-hypertension therapy this individual? Postprandial is 240. Fasting is 214. A1C is 7.28. BP is 180 by 100. How will he titrate?
Sir, please conclude.
That's all. This patient, immediately you should not take you have to take the history. This patient, he has forgotten the bedtime insulin, 13 units was not given for the previous day. And morning, the patient had 15 units. Because of, he has skipped the insulin in the bedtime, the blood sugar is 214. So 214 immediately will increase the dosage, patient will end up in hypoglycemic death, you can get it. And BP is 180 by 100. Do you take the antihypertensive regularly? Yes, sir, I am taking regularly. Do you have taken yesterday? No, sir. Last 1 week, I am not on. I have forgotten to take the antihypertensive drug therapy. Sometimes 1 drug, 2 drugs, bedtime insulin or morning insulin, they will skip. So the proper history take is very, very important. So to conclude my talk, hypoglycemia and hypotension is much more dangerous than hyperglycemia and hypertension. Thank you very much for the patiently listening.
Thank you, Dr. Palaniyappan, for your excellent revision of the diabetic hypoglycemia.
Sorry, sir.
Probably lack of time, you haven't covered the non-diabetic hypoglycemia like insulinemia and necidioblastosis, and more important nowadays is the post-bariatric surgery hypoglycemia.
May I request the chairperson to give a memento to the speakers, Dr. Indira and Dr. Palaniyappan. Great.
Yeah, thank you. Thank you, sir. Thank you, sir. Thank you.
Now. Somitro, please hand over the memento to Dr. Chakra.
Madam, you are actually.
And now you actually have a last session on ECG, but
Yeah.
before ECG there
Yeah,
is
please
another session on by clarinet, and before that.
Thank you.
Before that, we are running very short, and due to hurry, we have done a mistake. Actually, we have missed to give a medal to our ex-president of API, Dr. Bansode. May I request our president of API West Bengal chapter to give a medal to our ex-president API, Dr. Bansode.